In listen-only mode.
And nice to have you with me. I'm doing well. I hope you are as well. So let's go ahead and jump into this. Hello, Thiago. Nice to have you as well. We always do now start off, hi, Sheena, showing all of our new folks because we do enroll people into the program every 2 weeks. So every week we could have new people in Question Clinic. This is their first time being here. So in order for you to successfully interact with us, you do have to make sure you use the right method, right? Oh, Stephen's in Mumbai getting ready to take his exam. And look at him, diligence and commitment, still coming to Question Clinic right before he takes his test. So fantastic. That's awesome. All right, so guys, this is for those who may not have done Question Clinic yet. This is your first time. People tend to try to interact using the chat box. The chat box is not enabled for us on GoToWebinar. We use the questions box. So on your cell phone, if that's the way that you are attending today, look for the box that is labeled questions, right? So you should see something that looks a little bit like this little yellow outlined box here. It says questions with a question mark, okay, not chat. All right, you have to click on that box to get this box. And when you get this box, at the very bottom is a little tiny section compared to the big section up above, where it says enter message. That's where you enter your answers to the questions, as well as any questions you have about the questions or any comments you have about the questions. Everything goes into the same place. When you click send, it will show up on my side and I will verbally answer your question or comment to the class. So everybody gets the benefit of your inquiry, because I promise you, whatever inquiry you have, somebody else has that same inquiry, right? So make sure that you are using the questions box. And the same is also true if you're on your computer. You'll see there's a little navigation tool. If it's collapsed, it looks a lot like this. And it has a little bitty orange arrow at the very top. When you click that orange arrow, it will open it up to make it look like this. And again, there's a section labeled questions, not chat, questions. And in the bottom section of that little area, you will put your comment, your question, your answers to the questions and click send. And it will show up on my side. So I hope that makes it clear for everybody, but that's just so that people are aware the chat option is not enabled, okay? It's not enabled. You have to use the question option. If you can't find it on your phone or computer, you will have to reach out to GoToWebinar's website to find how it works for the kind of phone or computer you have. I'm not sure when Erica put this together for us if that was an Android or an iPhone presentation of the phone. So if you have the opposite one and you can't find the question section, you may have to go into the settings or into the GoToWebinar primary website to find out how to do that, okay? All right, so that being said, let's go ahead and jump into this. We always do start off by showing you how the exam is broken down by percentage, right? So if you're in your primary study, right, this schedule that you received on enrollment and you're working through those 10 modules and case studies and adaptive exams, you are learning your content by the body systems. However, the NCLEX exam and your adaptive exams that you take in Nurse Achieve are not arranged according to the body systems. They are arranged according to the client needs categories, and each of those categories addresses information from every body system. Right? It can be about anything. So the breakdown looks like this. And if you were to get only 85 questions on your exam, your breakdown would mirror this lowest end of the percentages. If you were to go all the way to 150 questions, your breakdown would mirror this highest end of the percentages. However, that's not the case for most people, okay? Most people get somewhere between 85 and 150 questions, in which case, depending on how you answer the questions, your percentage is going to be somewhere in the middle of those ranges, somewhere in between them. And theoretically, you could end up with a somewhat smaller section of the exam. For example, basic care and comfort, only 6 to 12% of the exam, could actually end up being a higher percentage, because you could go all the way to 12% if this was not a strong suit for you. If this was one of your areas of difficulty, you could end up getting a lot more questions, because it's trying to see how well you do in that category, and are you above the passing standard. So you could end up with 12% here, and maybe you're really super strong in safety and infection control, in which case you would get fewer questions and could end up with only 10% of your questions coming from safety and infection control, which would make this, quote, larger section of the exam actually smaller than this, quote, smaller section of the exam on your individual exam, right? So that's how the percentage and the adaptiveness of the exams works for the client needs categories and the way it's broken down. Now, these concepts that are in the purple band at the bottom of the screen, those are interwoven into all of the categories. So you can get questions in these content areas in any client needs category. They can be formulated so that, they address the pharmacological piece for documentation. They address physiological adaptation for culture and spirituality. They address safety and infection control for teaching and learning, or for clinical judgment, or you can find them everywhere, right? So that's just to help you kind of understand how the exam is actually formulated. All right, from there, we like to talk about what we're going to talk about, which this week is physiological integrity topics. That is a primary category for client needs that is broken down into 4 subcategories. And today we are looking at pharmacology and reduction of risk. So pharmacological and parenteral therapies covers expected actions, side effects, adverse effects, contraindications, and interactions of medications. It's a huge topic. It covers medication administration, pharmacological pain management, parenteral and IV therapies, total parenteral nutrition, blood and blood products, central venous access devices, and of course, dosage calculations. Then your reduction of risk covers changes and abnormalities in vital signs, therapeutic procedures, diagnostic tests, laboratory values, and potential for alterations in the body systems related to potential for complications from tests or treatments or procedures, or complications from health alterations and surgical procedures, as well as system-specific assessments. So those system-specific assessments tend to be those hotspot and kind of drag and drop kinds of questions. All right, types of questions you'll see on the NCLEX. Of course, you will have delegation questions, you'll have prioritization questions, you'll have therapeutic communication questions, you'll have decision trees, you'll have select all that apply. You'll also have case study questions that follow the clinical judgment measurement model. You will have to focus on what kind of question is this and what exactly is it asking me? And then which strategy am I going to use? Am I going to use the appropriate strategy for the kind of question? Am I looking at a logic strategy that overlays the other strategies? Or am I looking at how the question is set up? Because if I have a drag and drop, if I have a drop down, if I have a matrix grid, there's aspects of the questions that can help me with answering other aspects of the question. So all of these are pieces of the puzzle when we're trying to figure out the correct answers for our questions. We do always touch on therapeutic communication, because not only is it a topic in psychosocial integrity, but it's also a type of question and a specific strategy for answering questions. So we want to remind you to focus on a patient's feeling and tone in their statements, provide them clear and correct information, stay focused on the client, not minimizing their concerns or fears, but addressing them directly, using silence and our presence to give them space and time to think through their thoughts and feelings and verbalize what they're going through, avoiding the yes/no questions unless we're asking about possible self-harm or harm to another person, and avoiding those root cause, motivational kind of why exploring questions, and instead staying focused on behaviors and choices, right? That's where we want to focus with our therapeutic communication. All right, our 6 steps, of course, determining what type of question and what exactly am I being asked by this question. What is the topic related to that question? What keywords and clues do I see in the setup and the scenario to help me guide my thinking on this topic and applying what I know about the topic to the question, how it's asked? Then using the strategy for the type of question to review and eliminate answer choices I clearly identify as being incorrect, and reviewing the remaining answers to choose the correct answer based on the strategy and what I know about the topic, and does it actually answer the question, right? Those are all important pieces of the puzzle. So answering NCLEX style questions is not a rapid process, guys. You have to take your time. This is something we stress over and over and over, because I can promise you the overwhelming majority of people who don't pass the first time will write back and tell us, I was rushing at the end. I was rushing at the end. Do not rush your exams, because on your NCLEX, on your adaptive exams in Nurse Achieve, you do not have to answer all of the questions, and you do not have to be done in less than the 5 hours. You can use as much of the 5 hours as you need, and you want to use as much of the 5 hours as you need to answer however many questions they give you, and it doesn't matter what that number turns out to be. As long as it's more than 85, that's all that matters. So that's important for your process when you're answering questions on your adaptive exams and the NCLEX itself. All right, so let's look at question number 1. The nurse is working in the emergency department. Which patient should the nurse see first? Okay, when I look at this question, the first thing I need to do is, what is the question I'm being asked, and what kind of question is it? They're asking me who I should see first. First means prioritization. This is a prioritization question. They're not giving me any specific information in the scenario about the patients other than we're in the emergency department. That's a key word, guys. Emergency department. All right. So now let's look at who they give us and what's going on with them, right? And what do we think it means, right? This is that recognizing cues and analyzing cues that we use from the clinical judgment model. So first we have a 10-year-old with a severe neck muscle spasms who's taking haloperidol for Tourette syndrome. Second, we have a 75-year-old with irritability and agitation on alloprolizam for 2 weeks. Third, we have a patient taking clozapine who has a sudden onset high fever, diaphoresis, and change in mental status. And fourth, we have a patient taking olanzapine who has dry mouth, blurry vision, and constipation. So when I think about keywords, when I think about what I know about haloperidol and Tourette syndrome, what I know about alloprolizam and the elderly, what I know about clozapine and those symptoms this patient's having, what I know about olanzapine and the symptoms this patient's having, which patient do I think is at the highest risk to die, right? When you're prioritizing patients, that's a good starting point. Who is most likely to die on me out of these 4 patients, right? So there's always specific clues about a patient who's going down the drain, right? That's what we call it, circling the drain, right? So certain things should always stand out to us that this is going to be a big problem. This is going to be a problem. There's something bad happening here, right? So most of you guys on the right track. I got a couple that are looking in a different direction, but almost all of you are on the right track with this. So that's very good to see. All right, guys, we've actually spent literally 2 minutes on this question, which is about how much time you want to spend. So our correct answer here is the patient taking clozapine who has a sudden onset, that's always a high red flag word, high fever, another red flag, high fever, diaphoresis, and red flag change in mental status, right? Those are always critical problems. Sudden onset high fever, change in mental status. Diaphoresis can happen in a lot of situations, but it is a pretty serious symptom to tell you something's not right in the body, something's going wrong, right? So of all of these people, this is the person I would be most concerned about. The person taking the olanzapine who has a dry mouth, blurry vision, and constipation, those are normal side effects of that drug. There's not a threat there. The 75-year-old with irritability and agitation on allopurinol for 2 weeks, we know that benzodiazepines can cause irritability, irritation, confusion in our elderly, and so it is a concern, and likely we might be changing that drug, but we're not worried about them dying on us, right? Not worried about them dying on us. And then our 10-year-old with severe neck muscle spasms who's taking haloperidol for Tourette syndrome. That is a significant concern, and probably this would be the second patient we would go see, but again, not likely to die on us at this moment, right? That fever and the change in mental status makes us more concerned about this patient. Now, occasionally I have people choose number one because they think the neck muscle spasm is compromising the airway. That's an example of overanalyzing. There is nothing in the statement that says the airway is compromised. And most of us, at some point in our life, either we or someone we know has had what we in the United States call a crick in your neck, where your neck is spasmed over because you slept wrong or things were not, somehow or other you twisted your neck and it's hard to turn your neck. Right? It's the muscle that's the problem. It's not the airway, right? And typically those kinds of spasms don't affect a person's airway. So we want to make sure that stiff neck, right, is coming from the Tourette syndrome and the haloperidol. It's a side effect of the haloperidol, but it's not like meningitis, right? Stiff neck of meningitis, right? That means I can't bend my neck down where my chin touches my chest because of the inflammation of the meninges. That's a different kind of stiff neck. And so making sure we understand what is exactly being presented in the question, right? So I hope that helps clarify that a little bit. All right, question number 2. The nurse helps the physician perform a bedside thoracentesis. Right, so think about what we're doing in this procedure, right? It happens in a thoracentesis. In which position does the nurse place the patient to facilitate needle insertion and promote comfort? Right, so our keywords here: facilitating needle insertion and promoting comfort for a thoracentesis. Why do we do thoracentesis? What's going on in the body that makes us have to do this procedure? So knowing that, then how do we need the patient to be positioned? Should they be in the fetal position, lying on their unaffected side with the knees drawn to the abdomen and the hands clasped around them? Should they be lying on their affected side with the head of the bed elevated to 30 to 45 degrees? Should they be lying prone with their head turned towards the affected side and the arms over the head supported by a pillow? Or should they be upright, leaning forward over the bedside table with their arms supported on pillows? Okay. All right, you guys are doing a really good job here. Again, most of you are getting this one correct. Okay, I have a few of you off on a different direction, and we'll look at those. Our correct answer is an upright, leaning forward over the bedside table with the arms supported on the pillows. So remember, we're doing this because the person has a pleural effusion. We need to get to the side of the chest cavity. Thoracentesis are done by inserting a needle through the side of the chest cavity at the location of the pleural effusion, typically at where? The base of the pleural effusion. Why? To get all of that stuff to drain out when we do the puncture. But in order to get there, the arms have to be out of the way. So if the patient is sitting upright, that puts the drainage down. It's dependent according to gravity, right? And then leaning over the side of the bed with their arms across the bedside table allows them to have their arms out of the way and be comfortable during the procedure, right? As comfortable as possibly with people sticking a needle in your body. But it's the best position for them to be able to breathe during the procedure. Because why? When a person has pleural effusions, it's hard to breathe. So we really don't want them lying down, right? So prone is out. Fetal position is out because we don't want them lying down. And the fetal position is for what? A spinal tap, right? For us to do, look for CSF, right? It's not going to help with thoracentesis. So that gets 1 and 3 out of the way. Now, a lot of times and I noticed several people did choose number 2, and because they think about the elevated head of the bed, 30 to 45 degrees. So if a patient cannot sit upright, that would be the position. The problem with number 2 is it's the second choice position versus number 4, which is the first choice position. And it's got them lying on the wrong side. If they're lying on their affected side where the pleural effusion is, how are we going to get the needle into their body? Right? So it's always important. Pay attention to the wording. If this said lying on the unaffected side with the head of the bed elevated 30 to 45 degrees, that would be a correct answer, but not the best answer. And always remember, in NCLEX questions, best answer is your correct answer. So if I had to choose between that and number 4 still wins because number 4 is the preferred position for thoracentesis. Okay. All right, hope that helps. Number 3, the home health hospice nurse visits a client who is newly prescribed extended released oxycodone 40 milligrams scheduled every 12 hours to treat severe chronic terminal cancer pain. Which information is most important to reinforce to the client's caregiver? So a lot of keywords here. Hospice nurse, so end of life care with a patient who has severe, chronic, terminal cancer pain, right? So those words are very important. And it's extended release oxycodone of 40 milligrams. So does the nurse need to reinforce to the caregiver? What am I telling the caregiver about this medication? Number 1, administer the medication around the clock, even if the client denies having pain. Number 2, avoid administering with immediate release opioids to prevent respiratory depression. Number 3, change the dosage and frequency to 20 milligrams every 6 hours if breakthrough pain occurs. Or number 4, request a tapered dose from the healthcare provider if pain decreases to prevent tolerance, right? So this one is usually a little more confusing. I see most of you are still getting it right though, which is really great because that shows that you have a good understanding of extended release versus immediate release medications and this particular patient care scenario. So that's good to see. But a few of you are off on a different track, right? So let's think about this. Our correct answer is going to be number 1. Administer the medication around the clock, even if the client denies having pain. The reason for this is because chronic terminal cancer pain, right? Severe chronic terminal cancer pain. We never want to let this pain get out of control. And the extended release medications give very small amounts over the extended length of time that they are effective. So this is over 12 hours. So we are not building up an overdose situation for somebody who's taking this as prescribed. Extended release every 12 hours, okay? Now, the other piece of it is what typically throws a lot of people off is number 2, which says avoid administering with immediate release opioids to prevent respiratory depression. This is a patient who is in hospice care with terminal cancer pain. We are not concerned about respiratory depression in this patient, number 1. Number 2, the immediate release is what you use for breakthrough pain, not changing the dose or the frequency. We don't ever change dose and frequency without the doctor's order to do so. And it's not going to use the extended release to treat breakthrough pain. Your immediate release is what treats breakthrough pain. And if they should, let's say the immediate release was scheduled every 8 hours, right? And so it's time for the immediate release, and it turns out it's also time for the extended release. It is okay to give both of them at the same time because of the difference in the mechanism of action. The immediate release is going to address heavy pain, right now pain, right, to get them over the hump of that breakthrough or acute pain, whereas the extended release is going to help ease that pain over the long term. Okay, so that's why we do them together. And we're not worried about tapering the dose or preventing tolerance because this is a patient who's terminal. This is not going away before the person dies. So we are not concerned about addiction. We are not concerned about tolerance. We are not concerned about respiratory depression. The only thing we're concerned about is managing the pain and keeping them as pain-free as possible and as alert as the patient wants to be. Because sometimes the pain becomes so severe that the patient is willing to not be as alert in order to have the pain better managed. Okay. Now, some people are willing to tolerate a higher level of pain to be more alert. So we have to go with the patient in that situation. But in this case, we are not concerned about that. Okay. All right, question number 4. An experienced nurse precepts a graduate nurse in the intensive care unit while caring for a client with a right subclavian triple lumen central venous catheter. Which statement by the graduate nurse indicates understanding of the central venous catheter? So this is a positive query question. We're looking for the statement that is true, right? Which indicates, since this is a single answer question, the others are going to not be true, okay? So we're looking for the true statement. So is it true that all 3 lumens come together? So all drugs infused through the central venous catheter must be compatible. Is it true that it is used to provide enteral nutrition to the client who cannot eat? Is it true that sterile gloves must be worn when administering drugs through the central venous catheter? Or is it true that the lumen hub should be cleaned thoroughly with antiseptic before drug administration? Which of these is the correct statement about a central venous catheter that has 3 lumens? This one y'all are a little bit more scattered on, so we're going to focus on some significantly important words here that's going to help you with thinking through this kind of question when you encounter something similar in the future. A good number of you are getting it right, but a good number of you are getting this one wrong. Okay, so our correct answer here is number 4. The lumen hub should be cleaned thoroughly with antiseptic prior to drug administration, right? We always clean the lumen hub before we put in the medications, right? Because it's why it's been laying on the patient. We'll flush it, right? But we clean it before we flush it, and then we clean it before we put in the medications, right? We always want to do that. So why are the other ones not correct? Well, number 1 is not correct because that's not how central venous catheters work that have multiple lumens. When they have multiple lumens, the lumens come out at different places, The whole purpose of having a multi-lumen catheter is because that way you can give drugs that are not compatible because it's in a huge vein and that allows those medications to be given simultaneously, right? So number three is just not, number one is just simply not how they work, right? The catheter lumens are all separate and come at different spaces, so they go into the bloodstream at different points and allows them to be diluted by the volume of blood passing by, and so therefore incompatible drugs can be given through the same catheter but different lumens, right? It's about using different lumens. Number two is not correct because they are not used for enteral nutrition. This is tube feeding. They're used for parenteral TPN feeding, right? So it's different, not the right kind of feeding. And number three, sterile gloves are not required for administering drugs through the central venous catheter. So there's a couple of things here. You can wear clean gloves, but you can also just do good hand hygiene, right? You don't absolutely have to wear gloves when you're giving a medication, right? It could be, let's say it's something simple like Zantac, right? You don't necessarily have to wear gloves to administer the medication. It's not a bad idea, but as long as you're doing good hand hygiene, you're actually okay. But it definitely doesn't have to be sterile gloves. Clean gloves are sufficient. And this must work, right? Remember fixed language. If you haven't watched your decision tree webinar and Learn Upon, please do, right? I've noticed a lot of times when I'm checking people's Learn Upon progress, I see that one gets skipped for some reason. I don't know why. But fixed language must only always, those are those fixed languages that tend to make an answer choice incorrect, right? So when you see that language, you want to always question that's probably not a correct answer, because we are not required to wear sterile gloves when administering drugs through the central venous catheter. Clean gloves are sufficient, and even just good hand hygiene if it's not a caustic medication, okay? All right, number five. A hospitalized client is scheduled for a percutaneous kidney biopsy at 10 a.m. At 8 a.m., the nurse reviews the client's vital signs and most current serum laboratory results. Which finding is most important to report to the healthcare provider? A blood pressure of 180/100, a creatinine of 2 milligrams per deciliter, a hemoglobin of 9.8, or a platelet count of 120,000 millimeters cubed. Which one of these is the most concerning when considering that a patient is going to have a percutaneous liver or kidney biopsy at 2 hours from the current time? All right, a lot of you are getting this one right. That's good to see. You can't see the slide. Let me refresh the share. Sometimes that needs to be done. Very good. Shamil has given me a great rationale for their choice. Okay, our correct answer here is going to be number one. Number one, the blood pressure is the problem. So think about physiology, right? Your heart pumps the blood, comes out through the aorta. Where's the first places that the aorta goes, right? It sends blood to the brain. It sends blood to the kidneys, right? Those big pumps of your heart sending blood to the brain, to the kidneys. That's why people with hypertension end up with kidney disease, right? Because it's essentially blowing out their filter in their kidneys because of the pressure. So if I'm going to go stick a needle in the kidney, an extremely high blood pressure like 180/100 is a concern, because if I stick that needle in there, what's going to happen? Blood's going to spurt out. It's going to be a scenario asking for a hemorrhage. Now, the other ones are not normal values, but they're not unexpected either. Creatinine being elevated, hemoglobin being low, those are expected in a person who has some sort of renal disease, which if we're doing a biopsy on their kidney, probably got some renal disease. That's not an unexpected connection to make, right? Why else would we be doing it? And then the platelet count of 120,000, while it is below normal, it is still high enough that it is fine for procedures. Only neurosurgery and eye surgery require a platelet count of greater than 100,000. Other surgeries can typically be performed with a count that is as long as it is greater than 50,000. So this count of 120,000 is sufficient for us to do this particular procedure, but the blood pressure would be the problem. And at 8 a.m., we can call the doc, we can get an order for an antihypertensive and get that blood pressure down in time for them to do their procedure, right? Okay, you're welcome, Thiago. All right, let's look at our case study. Okay, so case study process, of course, recognizing cues, analyzing cues, prioritizing a hypothesis, generating some solutions to deal with that hypothesis, taking some specific actions, and evaluating outcomes. On your Nurse Achieve case study quizzes, on your adaptive exams, on your NCLEX, you will always have 6 questions in the case studies. In our question clinic, we only have 5 because we try to keep the whole clinic at 10 questions, so it's, time efficient, which means we typically blend a couple of these steps in one question or another. All right, so we have IM. The nurse is caring for a client diagnosed with Crohn's disease, scheduled for surgery for a small bowel resection, and possibly to create a temporary ileostomy the next day. IM is a 35-year-old female. She is 5'6", 165 centimeters tall, and weighs 120 pounds or 54.5 kilograms. She presented with complaints of progressively worsening diarrhea, up to 8 stools a day by the time she was admitted, and with severe stomach cramps times 8 weeks. She rates her pain at 7 out of 10 when the cramping, but states that after passing stool, it does lessen or resolve until the next bout of cramps. The pain is localized to the lower right quadrant, sometimes towards the umbilicus. She reports weight loss of 10 pounds in the last 2 months without intention. However, she has had decreased appetite because of the diarrhea and pain. She complains of feeling tired all of the time and sometimes feeling dizzy when she gets up from lying or sitting. She just wants to feel better and stop the diarrhea and pain. Her vital signs are a temperature of 100.8 Fahrenheit or 38.2 Celsius, a heart rate of 88, a respiratory rate of 20, blood pressure 120 over 76, and an SpO2 of 99% on room air. Okay, so this is our scenario for our patient. Take a minute to make note of the things, right, that you want to think about as you're moving forward in the case scenario, right? The things that stand out to you. All right, go back. Her lab results are still pending, but they have ordered a complete blood count, a complete metabolic profile, a C-reactive protein, and a erythrocyte sedimentation rate, a liver function profile, an occult stool sample for occult blood, and a stool for ova and parasites. And then her medications include budesonide, 6 milligrams by mouth daily in the mornings, adalimumab, 40 milligrams per 0.4 milliliters, pen subcutaneous injection once every 14 days, and loperamide, 2 milligrams by mouth as needed, up to 4 times daily. And then her physician's orders include a CT of the abdomen with oral barium contrast, a clear liquid diet, NPO after midnight, initiating a peripheral IV access, giving Tylenol 500 milligrams, 2 tablets every 6 hours around the clock. Diclomine, 20 milligrams every 6 hours. And the person can take their pain meds after midnight with a small sip of water. So now looking back at her background scenario, we want to highlight which findings require immediate follow-up by the nurse. So Immaculate's asking me to enlarge the screen. I can do that for a few minutes, so you can see that hopefully a little better. We'll have to drop it back down when we start doing the highlighting. And of course, you can try enlarging your screen too, Immaculate, but I'm sure you probably did that to begin with. So let me let you guys put out. We're getting some good choices here. Pain 7 out of 10. Progressively worsening diarrhea, temperature, her weight loss, decreased appetite, more pain, worsening diarrhea, feeling dizzy. Good. Okay. All right. Looks like we're getting most everything that I think we're going to be addressing. So that being the case, let me pull this back to, just back to our correct slide. All right. So we are concerned about the fact that she has progressively worsening and frequent diarrhea. She's having severe stomach cramps. Her pain is 7 out of 10. It is localized to the lower right quadrant. She's reporting weight loss of 10 pounds. And she's having decreased appetite because of the diarrhea and pain. She feels tired all of the time and sometimes dizzy. Okay. So all of those, which most of you chose all of those, I don't think we missed any of them, right? And then in addition, her fever is elevated, right? That's not a normal temperature, okay? It's not a normal temperature. So it is a concern as well because it could be a sign of a building infection. So all of these would be choices that we would want to highlight on a question like this. Anything. And so I will tell you that a lot of times in your Nurse Achieve, when they ask about immediate follow-up, they're really focusing on airway breathing and circulation, but that will not necessarily be the case on your NCLEX. They may be more like this, where it's just things that are not normal, not right, that you would call the doctor about, okay? So you have to think about kind of really what's going on in the scenario, because honestly, you look at this, she doesn't have an airway breathing or circulation problem at all, right? None of those. Everything else is just, it's a physical problem that she's having, right? So be aware that that can be the course. All right, now they want us to click to identify the appropriate drug class for the medications listed. So you should be studying your drugs by drug class using that table that we teach you to build in the Study Tips and Time Management webinar in Learn Upon. If you haven't been doing that, I would strongly recommend that you work on that. You should be doing a couple of drug class reviews every single day. Just when you start your day, whatever time of the day that is, look at a couple of those, review them. What is the information that you need to know? Somewhere around midday, look at them again. And then before you go to sleep, try to remember, what do I remember about those 2 drug classes? Right? And if you do that every day with a couple of different drug classes every single day, it breaks your pharmacology study down into smaller bites. As you go through the program, you're going to have more and more drug classes to look at, but they're going to be by body system, right? So you're going to be able to just focus on what you're studying for that 2-week period in your body systems, okay? All right, so we're trying to figure out, is budesonide a bronchodilator, a corticosteroid, an anticholinergic, or a biologic? Brian says he's struggling to read as well. So I will open this up a little bit. Hopefully this helps you guys. But make sure that you're enlarging on your side as well. If you're not sure how to do that, if you hold your control button down on your keyboard and scroll with your mouse, the little wheel, it will make your screen bigger or smaller depending on which way you scroll the wheel. Okay. Of course, if you're on your phone, you may not be able to do that so well. So hopefully this helps. All right, I think most of you guys are getting this one right. Budesonide is a corticosteroid. Oh, it's not going to let me do it. So while you're thinking, adalimumab, what kind of medication is that? Is it a biologic tumor necrosis factor blocker? Is it a monoclonal antibody? Is it an H2 inhibitor, or is it a proton pump inhibitor? And then loperamide, is it a probiotic, a laxative, a fiber supplement, or an anti-diarrheal? All right, so let's put this back where we can actually do our selections. So budesonide is a corticosteroid. Adalimumab is a biologic tumor necrosis factor blocker, right? So this one is probably the harder one, right? You can probably eliminate proton pump inhibitors. What's that? Nexium, Prilosec, right? Omeprazole kind of medications, omeprazole, H2 inhibitors, Zantac, Tagamet, Pepcid, those kinds of drugs. Monoclonal antibodies, this would be kind of like if you weren't sure which one this drug was, you would be vacillating probably between these two. The key word here that can help you remember is this is a biologic drug. So you could figure it out based on that if you could remember that it's a biologic drug and not an antibody drug. Okay. And then your loperamide is an anti-diarrheal. Right? And so if you think about this one, is much more similar to, you could use that orange in the basket of apples logic strategy, right? Because fiber supplements, laxatives, and probiotics all help you go to the bathroom, right? Anti-diarrheals help you not go to the bathroom, right? So it goes in a different direction. All right, now here's all of our background information that we had from the beginning with her physician orders, her medications. Her labs have now resulted, right? So her white blood cell count is 13.2. Her ESR, erythrocyte sedimentation rate, is 60. Her potassium is 3.2. Her hemoglobin is 10.5. Her hematocrit is 32%. Her C-reactive protein is 90. Her sodium is 132, her calcium is 8.2, and her albumin is 3 grams per deciliter. So based on the results of the lab work now received, what medication does the nurse anticipate receiving priority orders for at this time? So when I look at this, I'm thinking priority orders, the most important ones, the things that needs to be addressed first, based on the lab results. That means I'm thinking about what's the most out of whack, right? What's the biggest problem here? Is it her white blood cell count? Is it her sedimentation rate? Is it her potassium, calcium, sodium? Is it her C-reactive protein, her H and H, or her albumin? Which one of these is the most out of whack? That's what I'm going to probably focus on. And then I want to see what options do they give me, because maybe what I'm thinking is not what they're going to give me an option for, right? Sometimes that's the way it works, right? So is it administer 1 unit of packed red blood cells stat? Is it potassium protocol to 4.5? Is it hypertonic saline 1 liter over 10 hours? Or is it Zosyn antibiotic IV every 6 hours? Which one do I think is the most important to give right now, based on what's going on in this entire scenario and her lab results, right? You have to take her whole picture into play. What's going on with her? What are we going to be doing with her? And what do we have time for, right? What do we need to do? How effective or how fast do these interventions work, right? So this one is a little bit tricky. A few of you are actually getting it right though, which is really great, right? That's amazing, because this is one of those questions that tends to trip a lot of people up. All right, so our correct answer here is going to be the antibiotic, right? So and a lot of times people are going, but wait a minute, look at that potassium. Oh my God, she could have a heart attack, right? Right, that potassium's really low, and it is, but it's not considered life-threatening yet. Okay, that's one key point there. And actually the calcium and the sodium, those are all low, the H and H are low, but none of them are actually life-threatening yet. However, she's going to surgery tomorrow, and the surgery is a GI surgery, right? It's going to be a dirty surgery. So we want to get that antibiotic on board. She already has a fever and her white blood cell count is already elevated, right? And that CRP is high as well, indicating, as Stephen says, there's infection probably happening already. So let's get the antibiotic on board. And then in between the antibiotic doses, because it's ordered every 6 hours, right? We can do the potassium protocol. And then we can focus on, adding in sodium and calcium and, maybe doing a blood transfusion before the surgery, right? But that infection is the biggest threat right now, in light of the fact that tomorrow morning we're going to go open her up in a dirty surgery, right? So those are the elements that have to be taken into consideration here. So it's based on the lab results, but it's about also what else is happening with the patient, right? You have that global thinking process that's going on, okay? All right, next question. They want us to click or check to specify which nursing interventions are appropriate or inappropriate considering the patient's scenario. So easy way to do this is just list the appropriate ones. We'll know the others are inappropriate, right? So what should we do for our patient? Do we want to put her on ECG monitoring? Do we want to monitor her orientation and level of consciousness? Do we want to assess for false risk and assist with ambulation and transfers? Do we want to ensure all 4 side rails are up on the bed at all times? Do we want to monitor her vital signs every 2 hours? And do we want to put her on a strict INO and ensure that she is getting greater than 2,000 milliliters of fluids per day? Okay, all right, so let's go through these. Placing on ECG monitoring, most of you, I think, are choosing that one. It is definitely appropriate. We do want to monitor her heart rhythm because her potassium is low, right? It's important, and we want to do that. Monitoring orientation and level of consciousness. Yes, we want to do that. Why? Because one of the first things that goes when people's electrolytes are out of order, and she's got potassium, calcium, and sodium all out of whack, is level of consciousness and orientation, right? People become confused, right? And they end up, having a high risk for falls. So we want to assess for falls and assist them with ambulation and transfers. Now, putting the side rails up on the side of the bed does seem like a good safety measure. However, if we put up all 4 side rails all of the time, that's a restraint. Okay, so not appropriate, right? And again, there's that fixed language cue at all times. We don't do that, right? Side rails, typically in the US, it's upper side rails to use as enablers for the patient to move in the bed and to be able to get up and in and out of the bed safely. But we don't put up all 4 side rails unless the patient is actively having seizures, and we're using that to help pad the side rails, right? Pad the bed, right? That's it. Monitoring the vital signs every 2 hours, definitely we want to do that. And then strict I&O, that sounds like a good idea, but make sure that she does get greater than 2,000 milliliters of fluids per day. Not appropriate. Her electrolytes are already low. If we're giving her too much fluid, we're going to dilute them even more. Okay, so that's what makes this one inappropriate, because it's greater than 2,000 milliliters per day. That is not appropriate. Okay, so it's little things sometimes that can get us, right? All right, question number 10. IM has an uneventful night, and due to close monitoring and management by the nurse, the next morning she goes to surgery and undergoes bowel resection with temporary ileostomy creation. The nurse continues to monitor the surgical site, provide pain management and antibiotics as ordered, along with other ordered Crohn's management medications. The nurse provides teaching on the ileostomy management and incision care. Which of the following diagnoses does the nurse add to IM's care plan? Number 1, potential for bowel obstruction related to Crohn's diagnosis. Number 2, potential for electrolyte imbalance due to diarrhea. Number 3, potential for body image disturbance due to new ileostomy. Or number 4, potential for weight loss due to altered nutrition from poor oral intake. What is the one that we're going to add to her care plan? All right, you guys are doing pretty good with this one. Most people are getting it right. A few choosing a couple of the other choices. But our correct answer here is, what are we going to add to her care plan, right? Add to her care plan. Now that she's had the surgery, what's different? What's different is now she has an ileostomy. So number 3 is what we're adding to the care plan. The others would have already been part of the care plan, right? She's already had weight loss. She's already had electrolyte imbalance, and the potential for the obstruction already existed because of the Crohn's diagnosis. So these things would have already been in her care plan. The one that's getting added is related to what's new. She has a new ileostomy. The audio says, what? Oh my God. So yes, guys, this is why we always say we stress so much, right? Taking your time to think through the questions, because these questions are written weird, right? This is not normal kinds of questions that we typically would have seen as part of our nursing training or any other kind of academic experience, right? So no rushing, right? No rushing on your exams. All right, guys, if you have a slide that you would like to go back and see, I'll be happy to go back and do that. So Bright, on some questions, yes, you will get your ranges for your lab values, particularly in the case studies, you can expect to see that. However, some of the single answer questions, you may not, the standalone questions, because they may be presenting the scenario in such a way that they're looking to see, do you recognize what's normal or not normal? Okay, so don't expect that every question will have the reference range. But definitely in your case studies, you can expect that, okay? Review the question number 9, the monitor vital signs every 2 hours. This is because she has already got a fever and she's going to surgery the next morning. So we would still want to monitor her vital signs more often than just standard, right? More often than just standard. So every 2 hours would be the next one up, okay? Probably not less than 2 hours at this point for the vital signs, because we're monitoring her orientation, and she's going to be getting those labs addressed. At 2 hours is what would be probably standard at this point, right? Because she's pre-surgery, she's just come in. She's not in an ICU where we would be doing every hour, right? Cecilia, exactly where you typed your question. How do I type an answer to a question, please? That's where you type your answers. And when you hit submit, it comes over here just like that question did. Okay, you're welcome. All right, guys. Yeah, exactly like that, Anastasia. Just like you wrote this way. That's how you type in your answers to the questions or any questions or comments you want to make. All right, guys. Thank you so much for coming today. I appreciate having you. Hope this was helpful, and I hope to see you again next week.